We're definitely going to have a very deep dive in female hormones today. And I have to echo Dr. Hayes' sentiment that Mark has done a great job with this speaker lineup. And it really is an incredible group of speakers. But it's not only that he's attracted speakers to the podium, but he's attracted people in the audience. And when you hear us talk about estrogen metabolites and healthy ways that we can eliminate our estrogen and unhealthy ways that we can eliminate our estrogen, one of the pioneers in that field, Dr. Eleanor Rogan, is a researcher and happens to be here in the audience. And when I went up to her and I told her she was a rock star to me, it's actually a lot more than that, because she has influenced the way I teach, the way countless doctors have been taught and trained, and the way countless patients have been treated thanks to her works. So let's talk about now the hormonal axis. And it's really about physiology of how hormones are supposed to work that helps you understand what to do when the body's hormones aren't functioning the way they're supposed to. And in general, sometimes there's too much hormone or too much hormone effect or not enough hormone. And so how do we go through the testing process and the evaluation process through a good history, a good physical, and now we have great laboratory to help us figure that out. And so what we see here is a picture on the left talking about what happens with reproductive aged women who are still cycling. And what we see is after a menstrual period here, how hormones will gradually increase, and this is FSH and LH, which come from the pituitary to control the ovary to make estrogen, to pop the egg, and once the egg happens, then progesterone is the predominant hormone. But you can see estrogen and progesterone come up, and then this diagram here, which is from a 50,000-foot view, looking at what happens premenopausally, around menopause and perimenopause, and postmenopausally. And so here you see high levels of estrogen and progesterone. And in perimenopause, this is why we call it a hormonal roller coaster. So you get a roller coaster through a big picture effect of decreasing hormone. And then ultimately, we go into menopause where hormones are low. And one of the constant themes here is we see a little bit of estrogen always higher than progesterone. This is the steroid pathway. This is what really scares and frightens everyone that comes to my IFM lectures. And really, it's not scary, because all you really need to know are the big pictures about steroid hormones all coming from cholesterol. You've heard a lot about what happens in the adrenals, and what you can see, and this is determined by tissues and determined by enzymes. So what makes cholesterol go into cortisol as opposed to testosterone? Where the cholesterol is. So if it's in a tissue that's going to be making sex hormones, it's going to make sex hormones. And what is it specifically about being an ovary or a testes that makes sex hormones be produced? It's whether or not there are enzymes there. So it's the presence or absence of enzymes that determine what's going to happen to the cholesterol. So this is a bigger view of what happens within the menstrual cycle. So we start with FSH beginning to increase after a menstrual period, And that FSH, follicle stimulating hormone, stimulates the follicle or the egg to make estrogen. So FSH makes estrogen, and it makes estrogen in a slowly increasing way until it reaches a threshold. And this threshold is different in every woman, and it's different in the same woman month to month. So it's very variable. And that threshold then triggers a surge in something called luteinizing hormone. That luteinizing hormone is what causes the egg to be released, and then the part of the ovary that remains after the egg was exposed is called the corpus luteum. And that corpus luteum is the part of the ovary that then makes progesterone in that particular cycle. And this is what you see. So you can sort of deduce right away from looking at this graph that if ovulation didn't happen because there was a problem with this mechanism, and remember I said LH comes from the pituitary, and the pituitary is told what to do by the hypothalamus, and the hypothalamus is told what to do by our emotions and the way we think. And there are lots of ways that this can be disrupted, in which case ovulation won't occur. And if ovulation doesn't occur, in addition to not producing an egg from the hormonal perspective, we're not going to be producing progesterone. And that's going to create an imbalance between estrogen and progesterone. This imbalance between estrogen and progesterone, meaning more progesterone compared to estrogen, is what's supposed to happen. It's not pathological. I don't even want to call it an imbalance. But that's what's supposed to happen. And when this isn't here, because the corpus luteum doesn't make enough progesterone, and there's a lot of reasons for that as well. So when you have less progesterone relative to estrogen, women are out of balance again and have a whole different list of complaints. So we're going to go through all of that as well. So these are just the basics so you understand the symptomatology that your patients come in with and how it relates to the hormonal physiology. The final point I'm going to make on this is this bottom line here is the lining of the endometrium, which is the inside of the uterus, and this is what sloughs off and makes a menstrual period. And this is responsive to estrogen and is stabilized by progesterone. So an imbalance with estrogen and progesterone leads to an imbalance in periods. And there are many ways that that can manifest as well. But the uterine lining is what we call a good soldier. It does what it's told hormonally in reproductive age women. As women get older, and I hate to use the number 40 because that's young, but after age 40, that's where things can happen where the uterus can have a mind of its own, and sometimes things happen that trigger abnormal bleeding that have nothing to do with hormones. Or maybe there's fibroids, so there are exceptions to that. But in general, the uterus is a good soldier and does what the hormones tell it to do. Again, the same slide I showed you initially, that what happens as we go through the cycle of premenopause to perimenopause to menopause or postmenopause is, remember FSH, which is what causes estrogen production, that ultimately becomes very high because when we're in menopause and there are no follicles or eggs left, the body's still trying to make eggs. Just like in the thyroid gland, if someone's had their thyroid removed, their TSH will be very, very high if they're not on the right amount of medicine because the body's trying to make the thyroid hormone that it senses isn't there. So the body is trying to make more estrogen, so presses the gas pedal down, and that means high, high, high FSH. That's why that's one of the tests. If we don't know why a woman isn't having a period, Is she in menopause or is there something else going on? Let's check an FSH level and an estrogen level. And if this FSH is high, then we think menopause. FSH low, we don't think menopause. And then, of course, what complicates my life and the lives of my patients is that that can all change rapidly. 2 weeks later, all of a sudden, that FSH is flip-flopped. So it's a challenge. So estrogen upregulates the female reproductive system. And really, it is a growth hormone in a way, produced from the ovaries, and it always comes from androgens. So this is such a very, very important point. You can't have any estrogen anywhere in the body unless it comes from an androgen. That happens inside the ovary. The ovary is a two-cell organ, in a sense, when we're talking about producing estrogen. The theca cell and the granulosa cell. The theca cell making the androgen, the granulosa cell making the estrogen. So you actually make androgens in the ovary that are transported from one cell type to the next, and then when the granulosa cell gets the androgen, it turns it into estrogen, and it turns it into estrogen through an enzyme called aromatase, which is very important because aromatase is in other cells of the body, and there are many, many, many factors that can either upregulate or downregulate aromatase. So estrogen increases as the menstrual cycle goes. We saw that on the graph. Estradiol is produced from conversion of androgen, androstenedione, to estrone, and then estradiol. And in order for hormones to have an effect, they have to bind to a hormone receptor. Now, progesterone. Progesterone is so important. Conventional doctors historically have really neglected progesterone. There's not a ton of studies on what it does. There's a little bit of confusion. I'll never forget in my training, and in residency training as an OB, yes, there's didactics and lectures, but it's really from the people above you. And so here I am, a second-year resident, which is the first time we were allowed to really do any GYN, and I'm in the ER and someone has irregular bleeding, and I go to my senior resident, well, how do I know if I'm giving them progesterone or giving estrogen? That's a big question that OBGYNs have to figure out when someone comes to them with irregular bleeding. And the answer was, nobody really knows. It doesn't matter. Pick one, start with it, and if it doesn't work, that's how you know to go to the other. We now know that that's not the way to approach things, but that's how I was taught, and I'm going to show you how we'll address that. So progesterone really is not well known. Now, postmenopausally, there's not a lot of it around. We tend to give progesterone to our menopausal patients if we're giving them estrogen and they have a uterus. And it has receptors, as I said, as do estrogens. So here we have the hypothalamic pituitary gonadal axis, where I said there's the hypothalamus that tells the anterior pituitary what to do. It does that through a hormone called gonadotropin-releasing hormone. You heard a little bit about that earlier today, about pulsatility and frequency of pulses of GnRH and how that can lead to more LH or more FSH. And it is really one of the most precisely secreted hormones in order to create normal menstrual flow. So it is abnormalities in GnRH secretion that are caused by stress or depression or issues with eating disorders or with exercising too much. There are lots of ways that this can be out of whack. And when this is out of whack, the anterior pituitary doesn't know what to do. So it doesn't know how to secrete the LH and FSH. So then the estrogen and the progesterone secretion get all messed up. Ovulation becomes irregular or absent. You end up with hormonal symptoms. Usually, if we're not talking about menopause, they're hormonal excess symptoms, because this irregular secretion of hormone causes hormonal excess symptoms, which are breast pain, bloating, heavy bleeding, irregular bleeding. But sometimes, if the FSH and LH are not secreted at all, we get hormone deficiency symptoms. So you can have runners that have estrogen levels that are lower than some of my menopausal patients. And again, as there's more estrogen, lining gets thicker. So when women bleed heavily, it's safe to assume, and again, these are the younger reproductive age women where we're not talking about cancers or polyps or fibroids or anything like that. But the younger reproductive age women, when they bleed heavy, it's a lot of estrogen. It's estrogen dominance. And so the pillar of health perspective is so important also in the female menopausal arena or the female hormonal arena. So don't forget, it's complicated. So what that means is you don't have to figure all of it out at once. One of the things that we say in the hormone module almost through every single lecture is you can't have balanced hormones unless your life is in balance. How do we define getting your life in balance? It means everything other than the physical, so your relationships, your stressors, your lifestyle factors, your diet. So you have to get your life in balance, and then you have to have a balanced functional medicine matrix. Or if you don't use the matrix, whatever you're using in terms of functional balances or imbalances, you have to try to balance all of the non-hormonal areas before we can achieve hormonal balance. And when people come in to see me, I can't tell you how often the request is, I want you to balance my hormones. And then I'll say, depending on whether they're an old patient or a new patient, I won't be flippant, but I'll essentially want to know, well, tell me about your life, what's going on in your life. And I'll say, I'll do my best, but I just want you to know we're not going to get you to where you want to go until you've addressed these other issues. You don't have to solve all those other issues, but just knowing that you're addressing them will take away some of that stress from them so that your hormones will have a chance to reset. So it's all about the gut, right? You can't have healthy hormones without a healthy gut. And you just heard how stress impacts the gut in minutes, or TBI in minutes. So you change your microbiome in minutes. That's one of the questions I have about this whole emphasis we all have about gut microbiome testing, because the microbiome has such variation based on what we eat and how we think and feel. So I haven't figured out my usefulness and how to use all of that sophisticated microbiome testing yet, because it's so variable. But you can't eliminate the gut hormone axis. And as we know, the gut-brain axis, and what's in the brain but the hypothalamus and the pituitary. So this whole gut-brain axis becomes a gut hormonal axis. And we'll show you how, stress impacts ovaries. It's just all related. So at IFM, when we always say start with the gut, for people that don't know what's going on with the patient and need a place to start, by doing that, you'll also help hormones. And how many of your patients that come in looking like this, and again, I see a lot of them, have gut symptomatology as well, because it's bi-directional. So, dysbiosis, gut changes hormone levels. How funny that this is what I was just talking about 5 sentences ago. You'd think I made the deck. So, dysbiosis affects hormone levels. So, there's an enzyme called beta-glucuronidase. You only have to worry about that name if you're doing testing. But basically, this is an enzyme that's produced by gut bacteria. And this enzyme leads to increased estrogen levels. It does that by taking the estrogen that's excreted in the gut, because that's one of the ways that women get rid of estrogen is gut and urine, so gut and kidney. So we take the estrogen in the gut, and it cleaves a molecule, so it gets reabsorbed. So dysbiosis leads to more estrogen reabsorption. Now, you can also have too little of this enzyme if you have dysbiosis with different abnormal bacteria. Clinically, I see this less. What I see is increased beta-glucuronidase, and that's a big deal for patients with fibroids, endometriosis, or breast cancer. So as I said, too much increased estrogen. Increased intestinal permeability, that's leaky gut. Leaky gut is LPS, lipopolysaccharides, right? Now, there are tests now that measure anti-lipopolysaccharide antibodies as a way to diagnose leaky gut. There are many ways to diagnose leaky gut, but when you have leaky gut, by definition, you're going to have inflammation because you're going to have molecules that are supposed to be intraluminal, stay in the gut, they go into systemic circulation. So it's something from a cell membrane of a bacteria or the cell wall of a virus. And that inflammation leads to low corpus luteum function and decreased progesterone. This is a wonderful paper. It's in your references. And this is how I connect people that come to me for irregular cycles, short cycles. So short cycles are less progesterone. So short cycles, people that want to be evaluated for fertility status. This is why we're checking on your gut to make sure you don't have leaky gut, because that will change progesterone secretion in your ovary. And increased inflammatory markers suppress all ovarian hormone production. So we have a slide of IFM of all the enzymes in the ovary that are inhibited by inflammation. And it's essentially almost every single one. So, you know, by the end of the day, you'll know what you do no matter what your patient has, right? You want them to sleep, you want to reduce their stress, you want to normalize their gut, you want to attack inflammation and get rid of free radicals. If you do that, you're really pretty much doing almost everything. So, since so much of the immune system lives in the gut, dysbiosis leads to worsening inflammation. And it's a vicious cycle. Foods have an important part of this. So use either an elimination diet to identify foods people shouldn't eat, or do food sensitivity testing. But something, because people eat 2 or 3 times a day, unless you're a functional medicine faculty and you're saying should it be 1 or 2 times a day, but most people eat 3 times a day, and you don't want to eat foods that cause inflammation in your body. And healthy gut and happy brain means happy hormones. So let's talk about some of these common inflammatory issues or premenopausal hormonal imbalances that are usually due to some aspect of inflammation. What you eat, just what I talked about, right? But it's not only about foods that cause inflammation, it's about foods that may have hormones in them. So let's talk about soy. There's nothing wrong with soy as long as it's non-GMO. GMO soy really should be labeled as a poison. But non-GMO soy is okay. It's not going to give anybody a hormonally dependent cancer. It's okay. But dairy, if it's not organic, can have compounds in that increase hormone levels. In fact, if I were putting on a different hat, which is a medical director of a breast cancer nonprofit, and we talk about dairy, and we say that regular milk has more estrogen than we thought because they milk cows while they're pregnant, right? So if you're at risk for breast cancer or have breast cancer, you don't want to be drinking that kind of milk. And what I would say is that's the reason for low-fat organic dairy in that particular group. But the biggest, what I would say, dairy alternative or plant-based milk that people seem to like the best is oat milk. That's what people seem to talk about the most. This heightened stress response. So, what I will tell you is stress is bad for everything. It's bad for every single area in this pillar that Mark talks about. It's bad for every area of the matrix, and it's certainly bad for hormones. So stress messes up every single hormone and can even help predispose people to cancer. And you saw about that cortisol response curve being flattened and how that leads to earlier mortality in breast cancer patients. So we have to work on normalizing that stress response. And what I do clinically, I thought that was a great talk we heard about the car and how we want to get those interventions in really, really quickly. What I will tell you is another way to do that is just by helping people to take their regimens and not stress them that it has to be so quick, but they get themselves healthier through taking their supplements when they take their supplements, and then the car gets better. So the car will get better as people get healthier and less stressed. And then if it doesn't, that's when I tell people to have their supplements by their bedside. But I don't start out that way, and I think we all have different ways of doing things. And we talked about toxins that are, so toxins are all over the place, and toxins usually have hormonal effects. They act in the body and stimulate hormone receptors, usually in excess. Sometimes they block, and so if women are pregnant, male children can be born and have issues with reproductive health. If women are reproductive age, they can have issues with increased risks of breast cancer. So you can't minimize, I learned from Dr. Hayes years and years and years ago, the first time I had heard her, about the thousands of chemicals that women put into their body before they even get to work. And so we have to pay attention to that. Environmental Working Group has done studies, and there are lists of sort of cosmetics that are toxin-free. And I encourage you to all as practitioners to become familiar with that. And one more thing about this heightened stress response is that your stress response is programmed, our stress response is programmed in our bodies when we're in utero. And so it's so important to talk to our patients that are considering pregnancy about the importance of adrenal health, because trauma and stress in pregnancy can actually lead to a disordered HPA axis, a disordered stress response, and people become hypervigilant and angry and more prone to violence. So, common etiologies of hormone imbalance: obesity. Obesity, what does obesity do? Obesity causes more estrogen. Elevated or abnormal blood sugars, more estrogen. We'll go into this for sure. Diet and nutrition with food sensitivities, eating disorders, etc. And then congenital adrenal hyperplasia, which is where we don't have the enzymes to produce cortisol. Alcohol, smoking, not enough sleep, stress, pituitary lesions, wrong issues with genes we're not methylating, and a problem with the gut. So hot flashes and night sweats are due to low estrogen and low progesterone, insomnia, vaginal dryness, brain fog, bone loss. Mood issues, weight gain, decreased libido, infertility. Estrogen dominance, mood swings and anxiety. Dysmenorrhea, menorrhagia means heavy blood flow. Dysmenorrhea means painful blood flow. Breast tenderness, PMS, weight gain, swelling, acne. You can see hormones can be responsible for most everything your patient comes to see you with. So let's talk about estrogen dominance. This is the fatigue, the mood, the weight gain, PMS, headaches, stress. This is what we see, and here we see elevated estrogen and low progesterone. That's estrogen dominance. Either there's too much estrogen or there's not enough estrogen relative to the amount of progesterone, so the progesterone is low. So it can be either. So estrogen dominance, high estrogen compared to progesterone, even though both can theoretically be normal, there's no idea really what the ideal ratio is, and it varies, as I said, between patients and within the same patient. And when we see increased breast density on mammogram, that's a sign of increased estrogen and breast cancer risk, as well as increase in the cell type, what we call endometrial hyperplasia and endometrial cancer. So the drivers, the pillars of health: inflammation, because inflammation stimulates aromatase. Aromatase is that enzyme that makes estrogen. Obesity and visceral fat. Why? There's aromatase in visceral fat. Remember I told you there was aromatase outside of the ovary. Then we've got endocrine disruptors. Those are the chemicals we talked about in makeup, cosmetics, milk, foods that aren't organic, pesticide residues. We inhale them. We're all exposed. That leads to HPA axis dysfunction. Our gut, increased beta-glucuronidase because of dysbiosis, leads to elevated estrogen. And we could have ovarian cysts that are estrogen producing. So that's estrogen dominance. So it can be caused by, and we'll just go around the circle, gut dysbiosis, abnormal problems with diet. So too many calories, too much sugar. Nutritional deficiencies, too much cortisol, not ovulating. Whether we're taking birth control pills or hormones, that can lead to an imbalance. The environment, which we talked about a lot, and then estrogen metabolism. And we're going to talk about estrogen being eliminated through phase 1 and phase 2 and even phase 3 detoxification. So we see this with PMS, luteal phase defect, when there's not enough progesterone in the second half of the cycle. endometriosis, which we'll talk about, fibroids, which we'll talk about, breast cancer. And for any of these, there may be a need to support progesterone or lower estrogen levels or do both. So, PMS, luteal phase defect, endometriosis, fibroids, breast cancer, and now we'll start with PMS. So, anything that happens in the second half of the cycle, it doesn't matter what it is. It can be a physical symptom or an emotional symptom, but it has to happen repeatedly, and it has to go away when the period starts or shortly after it starts. It's very, very common, and we don't know what causes it. But what we do know is that it has to do with a little bit of serotonin, and we know that it has to do with ovulation because it doesn't happen before periods or after menopause. And so it's a change in exposure to hormones or sensitivity to hormones, and it's usually too much estrogen, not enough progesterone, and stress. So if we look at all our patients with PMS, we'll usually find estrogen dominance, either because there's too much estrogen, there's not enough progesterone, with stress. That gives us the fatigue, the weight gain, the bloating, the breast fullness, the headache, the body aches, and the irritability, the mood swings, the sadness, the decreased concentration, the hypersomnia or insomnia, withdrawal from usual activities. This is why I said it can be anything. And the treatment is focused on symptomatic relief. And when I say symptomatic relief, we're trying to get the underlying cause addressed, and that then reduces the symptoms. So lifestyle and supplements, Mediterranean-like diet, complex carbs during that second half, increasing tryptophan. From that, some people give tryptophan, regular exercise, stress management, and sleep. Chasteberry, curcumin, light therapy. Good quality multivitamin, B complex, vitamin C, and magnesium. It's a lot of vitamin C and progesterone, which we'll talk about later, second half of the cycle. You don't do this all at once, and you always talk to your patients about resolving conflict. So now we have luteal phase defect. Luteal phase defect, as I said, is the second half of the cycle, and what we're supposed to have is a 14-day luteal cycle, and here we see maybe a week's worth, right? So we want to see progesterone up for a week, for 2 weeks. And when we don't see it, it's because the corpus luteum, remember that's what the part of the ovary that produces the progesterone after the egg is ejected, not enough progesterone. And that leads to problems with fertility and an early menstrual period. So we see a shortened phase, you have low progesterone, and you have secretory endometrium, which shows you that there was progesterone that was secreted. And the diagnosis can be confusing because of inconsistent criteria. So, we don't really do biopsies anymore. We do. We don't do a single progesterone level, but we try to do multiple progesterone levels. But really, it's a diagnosis of history. And what's nice about Dutch is that it's an average of the day's fluctuating levels. It's not just the time of day when the blood is drawn, and so cycle mapping is the best option. So here you can see that estrogen and progesterone go up, but it goes down, and it doesn't last very long. So the low progesterone production, and here you see we wanted it to go a little bit longer. So, changes in FSH and LH, again, we don't really study all that. It doesn't really matter because it's a diagnosis of shorter periods and symptomatology. These people are unable to maintain a pregnancy, so it's infertility and first trimester loss. So what do? Treat the root cause. And so the root cause, we support progesterone, like chasteberry. We reduce estrogen if needed, although that's not the key issue here usually. And we address stress, gut, all areas of the matrix. We're starting to see a pattern here. Endometriosis. Endometriosis is the presence of the uterine lining outside of the uterus. It's not supposed to have, you're not supposed to have uterine lining in your pelvis. If you do, that's endometriosis. A lot of infertile women have endometriosis, and it causes inflammation. And it's a result of inflammation. So now that we're really understanding gut health, we understand that when we look at the peritoneal fluid in women with endometriosis, it's filled with pro-inflammatory cytokines. It's a pro-inflammatory soup. Why is that pro-inflammatory soup there? It may be because of backwards menstrual flow, and these endometrial glands create an inflammatory response, but it could also be because of the gut. So when you have inflammation in the gut, those pro-inflammatory cytokines leak through, they diffuse through, and you see inflammation in the pelvis. So what do I think? It's a combination of both. So it's a pro-inflammatory soup. You can see it in other locations, and it causes painful intercourse and pelvic pain. Again, usually menstrual flow that goes backwards or this pro-inflammatory soup. So we see genetic predisposition. It runs in families. It's dependent on estrogen. If you don't have estrogen, you don't have endometriosis pain, because endometriosis is made of uterine tissue, uterine lining, which is responsive to estrogen. That's what I showed you that first graph in the beginning of the talk. It's what gets thicker and thicker and thicker during the menstrual cycle. So if there's no estrogen, that tissue isn't going to respond. We do find it gets a little resistant to progesterone. Progesterone still is something that we can try, but that tissue can be resistant to progesterone, which is why symptoms persist. And inflammation stimulates endometriosis to go like crazy. That is a fertilizer. Pro-inflammatory cytokines are a fertilizer for endometrial tissue. So it's estrogen dependent, and guess what? These endometriosis implants have aromatase. So they make their own estrogen. They're on autopilot. So they make their own estrogen. The uterine lining doesn't make its own estrogen. Remember I made that comment about it being a good soldier? Because it's told what to do. But when it becomes an endometriosis implant, it makes its own estrogen. So the things that stimulate aromatase stimulate estrogen production in endometriosis. Guess what are the main drivers of aromatase in endometriosis? Pro-inflammatory cytokines. So that pro-inflammatory soup that's there from either the gut or just the fact that you have an endometriosis lesion, endometriosis tissue where it shouldn't be, stimulates it to continue to grow. It's that feed-forward cycle. And that causes more inflammation. Then there may be a little resistance to progesterone. So well-meaning physicians give progesterone to treat endometriosis. And just like that ER resident told me, sometimes it'll work. And really, sometimes it does, even though the textbooks say the progesterone receptors aren't there. The inflammation, this is the most important thing, right? This is the fertilizer. Peritoneal fluid macrophage. There's every molecular mechanism about inflammation is present in that peritoneal soup in endometriosis. So conventionally, it's birth control pills, it's medication, it's surgery. What do? We reduce production of estrogen and we improve elimination. Root cause medicine. Fibroids. They're estrogen dependent. We know that because you don't get them before your period, and after menopause, they shrink unless you're overweight with too much visceral adipose tissue, which means you've got too much aromatase in your body and you make a lot of estrogen. Then they won't, but in general they do. So we don't see them, as I said, and before periods. They should shrink and they enlarge with pregnancy. Usually when they're early, there are no symptoms, and the GYN just finds them on a routine pelvic exam. Or you can have symptoms like abnormal bleeding, pelvic pain that is throughout the cycle, pelvic pain during intercourse, abnormal bleeding. The reason for the bleeding is the fibroid is this fibrous tumor, and this fibrous tumor can't allow the uterus to contract to stop the blood flow, or the mass effect. So, smooth muscle cells transform and become sensitive to estrogen and also have their own source of aromatase. Uterine muscle doesn't have aromatase. Fibroid, which is a benign tumor of the uterine smooth muscle, does have aromatase. What does that mean? The things that stimulate aromatase stimulate fibroids. I didn't tell you one of the other potent stimulators of aromatase is insulin. So this is why women that have problems with blood sugar have more fibroids, more endometriosis, and more breast cancer, because if you stimulate aromatase, you're going to make more estrogen in the body. And if you have more circulating estrogen, you're going to end up with increased risk of breast cancer. So women that have diabetes, type 2 diabetes, not only do they have more breast cancer, but once they're diagnosed with breast cancer, they're going to recur more frequently and unfortunately have earlier mortality. So fibroids are estrogen dependent. They're an inflammatory disorder because the inflammatory cytokines that are circulating in the body also stimulate fibroids. So if you're eating foods that cause inflammation, it's not going to be good for your fibroids. If you've got chronic knee or hip issues, it's not going to be good for your fibroids. Treat the matrix. If you're overweight, it's not going to be good for your fibroids. So most GYNs do what they're told in their training, which is to do nothing, unless fibroids get to a certain point where the symptoms aren't fixable. But an early asymptomatic fibroid, they're saying just wait until it becomes a problem. Why not do a functional medicine intervention so we can stop the growth? Not do medicine or surgery. So let's reduce production and improve elimination. So here we see, again, this imbalance between a normal progesterone and a high estrogen. This is normal progesterone and elevated estrogen. It's no surprise that this woman has fibroids. It would be no surprise if she had endometriosis, and it would be no surprise if she had breast cancer, and it would be no surprise if she had painful periods. It would be no surprise if she had heavy periods, and it would be no surprise if she had breast pain. We could do urine or serum, and the goal is balance. We want estrogen and progesterone to be balanced. We don't want estrogen dominance. So I showed you what the estrogen dominance looks like. Now you see what the balance looks like. This is what we want. And we get there by reducing production. We attack aromatase. So we reduce elimination, because we reduce inflammation, because inflammation is the fertilizer for aromatase. We want weight loss, and then we support the elimination of estrogen, which is through phase 1, phase 2, and phase 3, which means proper methylation, proper adding of hydroxyl groups, because that's one of the ways we get rid of it. And then I told you about beta-glucuronidase and it going out in the stool. And that means constipation is a problem, because if you're constipated, you can reabsorb that estrogen over time. When I first heard this and I started talking to my patients and I found that 80% were constipated, I thought it had something to do with me. Like, what is it about me that I attract constipated patients? And that really is true. I did have that thought. But we have to make sure that our patients eliminate regularly. So fat increases estrogen because obesity is an inflammatory state, right? Visceral adipose tissue. Visceral fat is hot fat. So visceral adipose tissue causes inflammation, which causes more estradiol. Increased estrogen leads to inflammation. Insulin stimulates aromatase, which makes more estradiol. Insulin decreases SHBG, sex hormone binding globulin, that compound that carries estrogen. You've got less SHBG, you have more free estrogen. Adipose tissue contains aromatase. Adipocytes contain aromatase. And if the adipocyte is too full of fat, it becomes problematic. Yes, there is such a thing as a fat adipocyte. So, achieve healthy weight, minimize visceral adipose tissue, hormone-free foods, decrease stress, decrease inflammation, support phase 1 metabolism with crucifers, diindolylmethane or indole-3-carbinol, upregulating the 2-hydroxylation, and we'll talk more about this later, appears to be protective. But too much 2 can lead to cancer promotion. So use things like DIM or I3C carefully, not indiscriminately. So here we see a young woman with estrogen dominance. All 3 or all 2 estrogens are high, E1 and E2. And then we can see the 16 is okay, but the 4, which is an unhealthy estrogen, is too high. That is the door for a problem, or the key for the problem. And so what we need to do is find a way to address this, and here we see E1 and E2 are up. So then we look and we see that we give DIM or I3C and everything changes. It's important to document changes, especially in women that come to you that are at high risk for breast cancer. So phase 2 support, NAC, adequate methylation, general liver support, artichoke, pomegranate, watercress, green tea, vitamin C, milk thistle, fiber, just whatever your choice is to get people to have regular bowel movements. So here we have a 30-year-old woman. She's not on birth control, mood issues, progesterone levels are high normal. That's a good thing, but elevated stool beta-glucuronidase levels. Remember, beta-glucuronidase will lead to increased reabsorption of estrogen. So here we have too much estrogen. And when we break it down, we have too much in almost all of the 3 different metabolites. And then we give calcium D-glucarate. That's what we use to help the beta-glucuronidase. This is the glucuronic acid. And DIM, or I3C, and it just normalizes everything. So what we want is balance. So what do we do if we see insufficient progesterone but normal estrogen? Because that's another reason to have a balance that's out of whack. Then what we do is we find causes for low progesterone. So we make sure the test was done. And I got to tell you, I like to think I'm perfect when I tell patients what to do, but I'm not. So I make this mistake sometimes, or the patients make the mistake, I don't know. But you got to reinforce when the sample was taken. If they're not ovulating, then you have to work on that one. Birth control pills will lower progesterone. Mirena will lower progesterone because it inhibits natural secretion, because these are very synthetic forms of progesterone, so you're not going to make natural progesterone medications or PCOS. You're going to hear a ton about that a little bit later. So what do? Weight loss helps progesterone in women that are overweight. Improving insulin sensitivity normalizes progesterone. This is how other hormones are linked to other hormones. Everything normalizing thyroid, whole foods, nutritional support, Vitex, or even giving progesterone, either a progesterone transdermal or a progesterone cream. So, what does estrogen dominance look like in this case? Normal estrogen, low progesterone. And here we see normal estrogen, normal progesterone, but low relative to the amount of estrogen. Now, looking at this, I can't tell you that there's an imbalance here. This is where you have to think about the symptoms that your patient is describing. Remember, there's no clear ratio here, but looking at this being at 12 o'clock in the middle of the dial, and this being here at 9 o'clock on the left, on the low side of the dial, we can infer that there's some sort of imbalance. But we know and are likely to believe that this patient ovulated. This one didn't because she didn't make progesterone. Remember, progesterone comes after ovulation. Progestation. So cycle mapping is the wonderful way to figure out what's going on because you get to see estrogen throughout and progesterone throughout. This is a great test. Ovulating, normal levels of progesterone and estrogen. What happened here? No progesterone, no ovulation. Estrogen didn't change. So very low levels, no ovulation. Remember I said you have to have that balancing increase of estrogen before you get that LH serve and ovulation happens. So no ovulation happened here because the estrogen level never started to go up. So a one-day test is only here, which is good if you're limited by finances. But in someone who's cycling, it's great to have the information for the whole month. Because if the cycle's a little off, the testing can be off. So here, estrogen is normal. Progesterone drops early. We have to worry about PMS. We have to worry about infertility. It all depends on what's going on with the patient. You have to put the lab test in partnership with the patient to figure out what's going on. But that's why I love cycling. Ovulatory peak, but estrogen is low, right? So estrogen's going up, progesterone is going up, but it's not going up well. So we have to think, inflammation. Remember I just said LPSs, that study? LPS causes low progesterone. So this is how everything interrelates. This is, functional endocrinology. So which estrogen would you catch in a one-day test? It's hard to see. You do a one-day test, as far as I'm concerned, only if you have to, not because you want to. So we always do a lot of serum testing in addition to Dutch testing, just to have things to compare, like what's going on with adrenals, SHBG, thyroid, prolactin, et cetera, and then I love the cycle mapping. So we test estrogen metabolites because it confirms the diagnosis of an estrogen that's elevated, an estradiol, an estrone, or an estriol. Then we can see the elevated metabolites, and it confirms the diagnosis. So here we see, and I love this quote here, that's a lot of estrogen. So this woman is estrogen dominant, she's got symptoms, she's got fibroids, and she's at increased risk for breast cancer. And it could just be from the 16, and that's more estrogenic. The 4 is more carcinogenic. And so this leads us to how do we address breast cancer risk? By lowering this estrogen dominance. That's the door we want to help our patients walk through. And we do that by looking and measuring their 2:16 ratio, measuring the 4, making sure they're methylating, helping the liver, etc. So we're just going to close on a case. Peggy's 32. She's got these estrogen-dominant symptoms of irritability, bloating, and breast pain. She's stressed, not only at work, but then when she comes home, unfortunately, she has to deal with the needs of her child, and she's got low libido. That's a shocker, right? So we see this high CAR. She's under stress. Again, another shocker. But now we know exactly what we can do objectively, right, to demonstrate improvement. And so here we see a cycle map, and here we see her estrogen at the top and how it's pretty high. It's above those black dotted lines, which are the norms. And then you see the progesterone on the bottom, essentially in the black. So we see estrogen dominance. And now, when we look here, we see the same thing with all of these estrogens elevated. And when you look at the progesterones on the right, they're normal. So this is a case of elevated estrogen, normal progesterone, estrogen dominance, and estrogen-progesterone imbalance. And we see this happens as we're going into menopause. We see this in perimenopause. And so as we conclude, we're going to talk about PCOS next with Dr. Felice Gersh, who gives a wonderful talk on this, and I've seen her and heard her many times. We're going to talk about specifically what to do for perimenopause, postmenopause, HRT monitoring, a lot of women's hormones.